لحضور هذا المؤتمر. بشكر الأستاذة الدكتورة إيمان المرسي رئيس اسم الأطفال. بشكر الأستاذة الدكتورة هدى سعود. بشكركم جميعا زملائي، أساتذتي، أبنائي. سعيدة جدا بوجودي معاكم. اتعرفت النهارده بوحدة البيدياتريك نيورولوجي في الأزهر. أتمنى يبقى بينا إن شاء الله بإذن الله لقاءات كتيرة. البرزنتيشن بتاعي هيبقى كيس سيناريوز stepwise approach and diagnostic pearls. حالات النيورولوجي محتاجة proper history, proper examination. يعني examination يعني زي ما بنقول للنايب بالظبط بالكلمة وبالحرف. Proper interpretation, and then you put differential diagnosis, you put investigation to reach your goal. يعني هي محتاجة دقة. أنا بحس إنها محتاجة وقت أطول، أو to my opinion يعني أنا باخد وقت طويل جدا مع الحالة زي نوابي. هبتدي بأول حالة. I have a personal history. A male child, he is 9 years old, a product of non-consanguineous marriage. He is the third child. Complaining of recurrent episodes of jerking, upper limb and lower limb, and falling down. The condition started 5 months before. يعني هو بقاله 5 شهور في الابيسود اللي بيجيله. There was a history of headache on and off, sometimes relieved spontaneously or with analgesic. And then headache was associated with sudden jerking of upper limb, trunk, lower limb, but the child is conscious. He is conscious during this episode. It was once per month. يعني كانت بتحصل infrequent مرة في الشهر. It takes around 2 to 5 minutes. Okay. The mother noticed he is becoming hyperactive, poor school achievement, anorexia, more attached to his mother, some psychiatric symptoms, and infrequent bad wetting. عمره ما كان كده. They sought medical advice and diagnosed as seizures. How to diagnose seizure؟ يعني أقول على الموفمنت دي أسهل حاجة وأهم حاجة إن أنا أشوف فيديو، أو هتحصل له الإبيسود قدامي في المستشفى. الفيديو بيساعد جدا. وبرضه بنسأل الأم. يعني أنا قلت للأم هي بتحصل له كتير، ما بيروحش مدرسة، لا بيروح. عمرها ما حصلت له في المدرسة. طب ليه؟ لأنه هي الأم بتقول كل ما يبقى involved مع أي حاجة ما تحصلش، لما يقعد لوحده تحصل. Is this a character of seizure? What's your opinion? أنا هوريكم الفيديو. This is not a character of seizure. And then التريتمنت طبعا اللي بدأ ياخده أخذ على طول anti-epileptic drugs. Some people بيبقوا يعني so afraid of the movement أو الإبيسود، وبيحذروا الأم لو ما خدش الدواء ده he's going to die. فهو مضطر إن هو ياخده as an anti-epileptic drug. Investigation before اللي اتعمل قبل ما يجيلنا. EEG was normal. MRI كان فيها small area at the right occipital subcortical region. Gliotic area likely hypoxic ischemic. يعني it's an old lesion. لا يبرر وجود الموفمنت اللي قدام. MRI whole spine was normal. هو قاعد يلف كتير، ودايما انا بقول ان الدكتور التاني بيبقى حظه احسن من الاولاني وبيسهل عليه التشخيص. MRV للبرين نورمال. فندس عملوا مره كان بيل اوبتيك ديسك. Repeated 2 weeks later it was normal. Episodes were increasing the last month. Perinatal history عشان يبرر الاولد insult اللي بان في الام ار اي. كان it was full term incubator care. وبالتالي هو قعد وان he required mechanical ventilation. نعدي الفاميلي history developmental everything is normal. The weight is okay. He is alert, cooperative, speech normal, cranial nerves intact, motor examination normal, sensory normal, back, gait, coordination, everything was normal. This is the video. ممكن حد يشغل لي الفيديو؟ يا شباب حد يشغل لي الفيديو ممكن؟
عند حنان يلا عند حنان.
These are the movements. Which type of seizure? Focal, not conforming, generalized,
معلش يا
myoclonic,
حبيبي
تشبه.
معلش.
These are not seizures. Do you agree? Do you start anti-epileptic treatment? No. Case summary: a 9.5 boy, hyperactive, separation and anxiety, عايز ينام مع مامته طول الوقت, bedwetting, anorexia, poor school achievement. The onset was dramatic with this movement. What you call this movement? These are choreiform movements. Symptoms at times increased, wax and wane, and sometimes remitting. The case summary: we have a child in the pediatric age, he's 9 years, with abrupt onset of the symptoms. I'm taking the first letter from every sentence. And then neuropsychiatric disorder manifestation, exacerbation with, let's say, with infection, علشان نبقى more close to the diagnosis. If you take the PAN, this is PANDA. PANDA is an autoimmune, pediatric, autoimmune, neuropsychiatric disorder associated with streptococcal infection. Investigation, we have done antistreptolysin or titr, it's high, ESR 2545, the throat swab, hemolytic streptococci sensitive to penicillin. Our drug of choice is penicillin. You can give the intramuscular, you can give the oral. Follow-up of our child started improvement. The frequency of episode was a bit far, once per month, and the duration is less, but still having the movement. This is an immune disorder, so next step will be also immune therapy. IVIG started 2 grams per kg over 5 days, marked improvement. He improved a lot. And the antistreptolysin go down, but sometimes if he has another episode of infection, sometimes the symptoms recur. Do we consider PANDA similar to rheumatic fever? The American Academy of Pediatrics and American Academy of Neurology recommended prophylactic antibiotics similar to rheumatic fever 4 or 5 years after the last attack or until age of 21, and the WHO also. Long-term prophylaxis is required. Case 2. A male child, 5 years old, presented with defective hearing and disturbed gait of 3 months duration. No history of fever at onset, no symptoms of increased intracranial tension, no history of seizures, no or disturbed consciousness. The child is alert in coordination of movement, upper limb, the gait, wide base gait, hypotonia. Motor examination reveals hypotonia, hyporeflexia, and Babinski flexor. This is a case of ataxia for investigation. You can put all the differential diagnoses, a very big list of differential diagnoses, starting from acute post-infectious ataxia, brain tumor, metabolic, and so and so. First investigation was MRI, it was normal, fundus normal, because he's complaining of hearing. So the ABR, the brainstem, auditory brainstem stem response, reveals or confirms the defective hearing. What about the family history? No consanguinity, he is the second child. This is very important. The history is very important. Respect the mother complaint, please. Go through all items of the history. His elder brother is 7 years old. He had history of acute onset of disturbed consciousness 1 year ago, and a state of encephalopathy with weakness of both upper and lower limb, MRI done, and diagnosed as ADEM, acute disseminated encephalomyelitis. MRI reveals multiple areas of abnormal signal distributed in the white matter. I think many of you have seen acute, right, ADEM, acute disseminated encephalomyelitis. This is an immune process, and the prognosis is excellent. regarding the recovery ranges between 70 to 80% of cases, and the treatment is immune therapy. The management included IV methylprednisolone in the dose of 20 milligram per kg for 3 to 5 days. This is a history. This is what he said, or he has, I think, a medical report on discharge. And then no improvement in the first hospital. Second line immunotherapy was plasma exchange, but still no improvement. Either he is from the group, they don't recover totally, or please revise your diagnosis, okay? He's not improving on immune therapy, and you are putting a diagnosis with ADEM or acute disseminated encephalomyelitis. The MRI of our child is normal. What about his brother? Why they diagnose him as ADEM? It looks like ADEM, really. Where is the cursor? You can see here, area of abnormal signal, and I need the first one. Abnormal signal of the white matter scattered. Another one, another patch. This is the T2 MRI here and there. So you have multiple areas of abnormal white matter signal, and you have acute onset, a state of encephalopathy. The first possibility is acute disseminated encephalomyelitis, but he did not respond to immune therapy. This is the coronal, I escape. It's okay, same. The elder child, he has progressive deterioration. You know, infection or post-infectious, the sequelae occurs immediately after the infection, okay? You don't find new symptoms after 6 months or more. You don't get deterioration, but you get sequelae. But this child has deterioration. Please revise your diagnosis. And he was wheelchair bound, and then developed defective vision. Could be sequelae of CNS infection. No, please revise your diagnosis. Now I have a family of 2 boys, 2 children, one with ataxia and one with query sequelae of post-infectious or immune-mediated encephalomyelitis. What's your opinion? Do we go through immune-mediated disorder, or we have to revise? I need to revise my diagnosis. Please consider genetic causes. The family, the father and the mother are not consanguineous. I'm not considering autosomal recessive. I'm considering X-linked. You don't need parents to be consanguineous. The family, case summary, family, no consanguinity, 2 male siblings having progressive neurological deterioration, ataxia, defective vision, defective hearing. Genetic causes should be considered, being 2 boys, X-linked disorders. Please consider X-linked leukodystrophy or adrenoleukodystrophy for the 2 children. This is not a simple immune-mediated disorders. And you have to check adrenal profile, because this is X-linked adrenoleukodystrophy. In 50% of cases, you should measure adrenal profile. Okay, it's low in 50%. And then this is a paroxysmal disorder, one of the white matter diseases, neurodegenerative disorder. You have 2 paroxysmal, the very long chain fatty acid assay, there is an abnormality in this metabolic disorder. The very long chain fatty acid, I mean the C22, the C24, and the C26, and you can assess or measure the very long chain fatty acid through gas chromatography, metabolic screening. Some countries have to diagnose these children early. They include the very long chain fatty acid in the neonatal screening program, because if you diagnose him early, you can do bone marrow transplantation and save the child. This is هو البوينتر شغال. You can see the C22, the C24, and then the C26. You can see that it is increased or high. The C24 ratio to C22 is high. The C22 to the C20, this one is high. These 3 are elevated. they are diagnostic of paroxysmal disorder, the very long chain fatty acid, the X-linked adrenoleukodystrophy, the childhood cerebral type. This is one of the two children. The other one here, same. You can see this one is high, C26, this one is high, and this one also, and the diagnosis of X-linked ALD. X-linked adrenoleukodystrophy. What about the parents? The parents هم مرتاحين للتشخيص بتاع الانفكشن، انما ان انا اقول لهم this is genetic، لا، هم parent denial، they don't respect this word. يعني كلمة genetic دي بتقلقهم جدا. احنا ما احناش consanguineous. Yes, you are not consanguineous. This is X-linked. Denial for genetic disease and I've never seen them back. يعني هي كانت آخر زيارة هم وروني بس الانفستيجيشن وما جيوش ناحيتي تاني. The first child اللي هو جالنا ال MRI normal. This is a very good chance to do bone marrow transplantation. But there are only two children. The first is also affected. You can take him as a donor for bone marrow transplantation. Leukodystrophy. This is a chart of many of our cases. أنا بس عايزة أوريكم ال MRI بتاعت ال time out. Okay. You can see the demyelination here. This is ممكن اوري ال MRI just 2 minutes. اللي احنا متعودين عليها في الادرينولeukodystrophy. This is صورة من الكتاب اللي هي demyelination is bilateral, symmetric, parieto-occipital, increased signal intensity of the white matter. In 85% of cases. انما الحالة بتاعتنا كانت widespread او disseminated وبالتالي اتشخصت أدام. أنا بس هدي summary والله خفيف جدا مش هاخد وقت. A male child هو طفل جالنا عنده 6 سنين non-consanguineous parents complaining of weakness of both lower limbs and the condition started acute onset weakness of both lower limbs. 3 days later weakness of upper limbs. وكان متحول لنا في أبو ريش على إنه جيامباري for IVIG. طبعا we respect the diagnosis and then we reassess ال symptoms. يعني هقول بس the child was referred to receive IVIG. There was history. ده مهم قوي الهيستوري. partial loss of head hair، يعني شعره بيقع وفي أماكن فيها alopecia وما بيسمعش. بس قالت لي ان هي راحت لدكتور ENT وقال لها دي ميه ورا طبله الاذن وبالتالي مش سكتنا، مش sensory neural deafness. الاكزامينيشن مبين الويكنس في اللور ليم في الابر ليم. weakness was asymmetric. This is not against Guillain-Barré. انما deep reflexes were present. الحقيقه I respect our neuropathy وال lost reflexes. امال هو ايه؟ الانفستيجيشن اللي عملناها برضو عملنا لامبر بانكتشر، ما فيش سايتو البومينس ديسوشيشن، عملنا فندس، عملنا ميتابوليك سكريننج. طبعا بعتنا سامبل للمينستري لانه جاي باكيوت فلاسيد باراليسيس. EMG كان مايوباثيك. قلنا يمكن من الاستيرويد، كان بياخد استيرويد علشان الهير لوس. كل يوم الام كانت بتسيبنا وتروح تاخد اراء وترجع لي تاني يوم يعني بعد الدور لازم ياخد IVIG. حبيبتي هو انا هديله IVIG من غير ما تلفي. قعدنا 5-6 ايام الولد was deteriorating. I have to مش قادره اقنعها، لكن لازم اربط الويكنس ولازم اربط الالوبيشيا ولازم اربط الدفنس اللي عنده. وطبعا كل دول بره الجيامباري. يعني الكرينيال نيرف ممكن يبقى 7 بالبر دول ده. الام سابتنا وعادت الانفستيجيشن ورجعت لي قبل ما تمشي. بس انا يعني فكرنا في حاجه اسمها بايوتينيديز ديفيشنسي، معاه الهيرنج لوس ومعاه الالوبيشيا ومعاه الميلوباثي او الويكنس اللي حصل لابنها. وبدانا بايوتين 10 مللي جرام توايس بير داي. بدانا 5 وبعدين 10. هي خرجت وجات لنا بعد اسبوعين قالت لي انا فعلا دفعت لكن ابني بدا يمشي. وقفتي الدواء؟ قالت لي زي بعضه عشان خاطرك انا اديته، لكن هي كانت بتقولي هديله قراص. طبعا يعني she was not convinced. This is a case of biotinidase deficiency and please طبعا عملنا لها البايوتينيديز activity it was 0 ومشي على البايوتين. الحقيقه الحاله دي من زمان قوي، من حوالي 16 سنه. هو الولد دلوقتي في كليه الصيدله اخر سنه. everything is fine زي الفل apart من الدفنس لأنه مش بسهولة يتحسن في حالات البايوتينيديز. أنا بشكركم جدا. I have to acknowledge my dear patients and their families and all members of the Neuropediatric Unit, Cairo University. بشكر all chairperson, بشكر كل speakers, بشكر all audience. Thank you very much.